Thank you, Mr. Chairman. Ladies and gentlemen, it's a pleasure to be here. And it's always great as a surgeon to give a talk on radiology. Bit of a fish out of water, but I will do my best. So I think we'd all agree that doing these operations on patients is one of the major challenges we all face. And the decision making about whether we ultimately do an operation on a patient depends a lot on presentation, on the comorbidity of the patient. Definitely depends on patient and surgeon attitude, but it depends a lot on interpretation of the imaging. Now, we're all in privileged positions, and if one of our family, our daughter, our mother, our wife, husband got ill and needed an operation, you go and find yourself a surgeon that you trusted, you thought had good skill. Well, it's not that different, I don't think, when dealing with one of these cases. I think it's about finding a radiologist in your department that has got experience, you trust, and is sensible. Because the radiology, as we all know, is often very difficult to interpret, often underestimates the extent of the disease, and clearly is very important when it comes to making the right decision about whether you operate or not. So the surgical objectives are pretty straightforward. We all know those. We've got to try and get disease control. We would love to get a R0 margin, and we'd love to leave enough liver behind so that the patient goes home. The challenges are fairly extensive. We've got the complex anatomy, we've got the extent of the tumour, which is often difficult to judge. Is there anything else wrong with the rest of the liver and parenchyma? Have they got PSC? Are they just got a cholestatic liver? The surgery itself, you're trying to get a margin, you're dealing with the bile duct and you're dealing with the vessels. And then now we've got neoadjuvant and adjuvant therapies which also have to be considered. So with radiology, we've got to make a diagnosis, that's the first thing. We've got to get a roadmap, decide what the ductal involvement is, what's the mass, what's the parenchyma like, what are the vascular involvements, and then is there anything else distant which may change the decision. So most people would start with an ultrasound. First line investigation in most parts of the world for someone who's got obstructive jaundice, and we're looking for the obvious findings. And then a lot of units will probably go on to an MR where you get a cholangiogram and you get a cross-sectional imaging. CT will be used in some places, but many would argue doesn't give you the best, as good a definition as MR. For distance spread, I think most people would consider PET scan, and we'll discuss that later. And then I think for intervention and therapy, the therapeutic options with EUS now, ERCP and PTC for drainage, not only gives you drainage with the latter two options, but also potentially gives you tissue and diagnosis. I'm not going to go through the histology, but just to say that the findings you find on radiology very much reflect the characteristics of the tumour in that it's got a lot of fibrotic tissue, occasionally has mucin present, and there's some cellular content. So a small mass on MR can be isodense, and it could be slightly increased intensity, particularly on a T2. It may have reduced intensity, or again in isointense on a T1. And I think with the gadolinium, it can be initially hypervascular, but then you get this delayed enhancement, which only the clever eyes will see. The trouble with these tumours, they typically are these periductal infiltrating lesions where there is often underestimation of what the extent of the mass and the extent of the disease. There's often neural and perineural lymphatic spread, which makes things even more difficult. And you can often be surprised when you get the histology report back after doing what you think is a very clear margin operation. So the radiological assessment will look at the ducts, it will look at the mass, it will look at the parenchyma, and then distant metastases. And here's just a quick example of an ultrasound that you might see showing intrahepatic duct dilatation. You then go on to your MR, and here you see a nice picture with segmental involvement. But then if you've got the delayed imaging with gadolinium, which you see the right two pictures, you start to see the mass appearing with your segmental ducts involved. With a bismuth type 3B, you can see on a nice MRCP involvement, particularly of the left side, but both sides are involved with duct dilatation. I think clearly ERCP and PTC are only really used for therapeutic options, but they do and they can give you more information about the ductal involvement. And here you see a nice picture of an ERCP showing you segmental ductal involvement on both sides. Once you've got a stent in, you can, I think ideally, as I'll show you in a second, it's ideal to get your cross-sectional imaging done before you've got the stent in place. But here's an example of an MRCP with a stent involved with a type 1 bismuth stricture. But you can see from this picture, you do get an inflammatory response to the stent, and once you do an MRCP and you get more enhancement, which can be confusing and mistaken for extension of tumour. So PTC, I know, will be used in many units around the world. We use endoscopic drainage as our first line. But again, PTC can give you nice definition of ductal involvement, as you can see on the left side with the left duct being drained. So to identify the mass itself, you often use this delayed method with gadolinium on MR, and you can see on the right side of the picture the mass coming up fairly obviously. You just need a radiologist to show that particular slide. And again, an intraductal polypoid tumour, again, obvious once you've got the actual slides shown to you when you're going through hundreds, sometimes thousands of different slices. It's really helpful to go through these pictures with an experienced radiologist. So segmental involvement is often beautifully shown with an MRCP, and here two good examples, particularly the one on the right, which is high segmental involvement. And this is a heart sink, isn't it? When you've got a Hilar cholangiocarcinoma with the background of PSC, these patients are always a real problem to treat. But you can see on this picture some clear beading particularly on the left ducts. So the other thing cross-sectional imaging will do is show you any lobar atrophy and perfusion abnormalities because of your vascular involvement, long-term vascular involvement giving you the atrophy. And of course, it will give you an idea about whether there's any fibrosis and cirrhosis already set in, either with background liver disease or because of secondary obstruction. And here's a good example of a patient with quite significant posterior sectoral atrophy, which is clearly important when making a decision on what sort of operation you're going to do. I mean, certainly in Leeds, we do volumetry, but we only do that for our live donor program. We don't do it for our resection program, but I know a lot of places in the world will do very careful volumetry studies for their resection work, including Hilar cholangiocarcinomas. So here's a good example of a perfusion artifact. You see the arterial phase on the left side and the portal vein phase on the right side, again showing you hypoperfusion on the left side. Here's a nice example of the MR showing you very obvious, it's easy when it's obvious, left portal vein involvement with stricturing of the left portal vein and a slight narrowing of the main and right portal vein. Arterial assessment can be also done obviously with MR in the arterial phase, and certainly the second along from the left shows you the artery phase showing up nicely. This is an example of how confusing, how difficult it can be. You know, you've got one slice on the left side which shows that right hepatic artery may be involved, but on the other hand, the next slice shows it actually may be clear. Here's a much easier case where you've got the left side and the right, and the next slice showing clear involvement and complete circumferential involvement of the right hepatic artery. Here. This is again an easy one with both portal vein and right hepatic artery involved. You can see that on the cross-sectional coronal of the MR. We don't do these routinely because we don't do many CTs for this disease, but if you have got the time, you can create these 3D images, and I know that my talk was supposed to include these, but we tend not to do them, but here's a reasonably good example of an inoperable case where there's both right and left stricturing of a right hepatic artery and left hepatic artery stricturing due to the disease. So another example of delayed imaging, 10 minutes of gadolinium, and you can see the mass forming with nodes around the hilum suddenly become really obvious. But what is difficult about this disease is deciding, especially if you don't get tissue or your tissue the tissue sample that you get back is unhelpful, is this an inflammatory stricture or is it indeed neoplastic? And here's an example that turned out to be an inflammatory stricture, but again, it could be easily taken for a Hilar cholangiocarcinoma. MR can be used for peritoneal disease, again with a delayed phase, and this sort of white sort of haziness around the liver will often represent peritoneal disease. But clearly for distant disease, in this disease, PET scans, CT is used in most places now. So just to give you a very quick example of having faith in your radiologist, this was a guy who was fit, came to me with a story of, he'd had a transient bit of itching, that was it. His bilirubin peaked at about 30, he became well, he went to the hepatologist and they sent him home, but they did go order an MR scan, thankfully. And he had his MR scan and he really was behaving like an inflammatory stricture, but my radiologist reckoned it was a cholangiocarcinoma, and indeed we went on, did the operation, left-sided resection, and he is fine, and it was indeed a cholangiocarcinoma. My point is, I think it's all about the teamwork. It's all about deciding who you work with in your radiology department, because I think most of us as surgeons will struggle to get an accurate diagnosis with many of these cases. So pick your colleague and pick your patient, pick the right horse, and give it a go. Thank you for your time.
Thank you, Dr. Toogood. Is there any question for this from the audience?
Derek.
Well, let me ask a question now.
Derek.
Oh, sorry, I couldn't see.
Thank you. Can I ask you two things? Staging laparoscopy, do you think that has any place in looking for peritoneal disease? And the second thing is, you mentioned PET scan in the beginning. Do you do PET scanning? Is it someone with PSC? Do you see any place for it in PSC?
Well, yeah. We do PET scans on all these cases now. We don't do laparoscopic, diagnostic laparoscopes on all of them. We do on some, and often it's on the ones that you're hoping there's a reason not to do the operation in a weird sort of way. But so we do routine PETs, but we don't do routine laparoscope, is the answer to your question.
Okay, anything else? Please. Please use the microphone.
Dimitris Zakaroulis from Greece. I was wondering, do you use the intraluminal ultrasound to define the extent of the cholangiocarcinoma? Because sometimes you have this paper-like distribution into the biliary duct.
No, we don't.
You don't?
No, we don't. Straight answer, we don't, no.
Yeah.
One question. You mentioned that you use ERCP as your preferred approach to drain these. And what's the rationale? Why not a BTC with these high lesions? Because we always worry about the infective complications if the ERCP is not successull. So can you please,
sorry, yeah. I think that there's more talks coming on that particular topic, and I know there'll be probably half the room who would probably use endoscopic approach as their first approach, and half will use percutaneous. We always go for endoscopic first. We find that it works in our unit. We've got a very good endoscopic team. Clearly, if we can't get drainage with endoscopically, we will then go to a percutaneous route. But it's worked well for us.
Okay, thank you, Dr. Toogood.